We're a bit late, but I would really like to hear if there are any thoughts from the audience about what you've heard this afternoon, or any questions that you have. Yes, yes.
Question, actually.
I take on board all your comments, and particularly just go back to the question that Ben asked me in terms of numbers of cases, and in reference to the discussions that we're having, I think just before lunch or just after lunch in here today about reference centres, etc. And if we kind of transfer that to this type of technology, what are your thoughts in terms of succession planning? And if we do have centres with big volumes, and maybe we can introduce this in those centres, how do we get new surgeons to be established? I mean, you're talking about consenting patients in the first 50 cases, but trainees coming through nowadays are not doing as many cases as I did when I qualified as a consultant, and I didn't do as many cases as you did when you were a trainee. And so there's a big curve happening, and how can we reduce that impact on the patient by proper succession planning? Are we looking at which trainees are doing these programs and how they fit in? And when you finish your, I'm not wishing you to retire or anything, Frank, but when you finish your program, who is going to succession plan all the fantastic work that you've done at Papworth? Is that something that is on the agenda for the whole society? Should we be looking at that?
Well, I think you raise a very good question, Ish, across the board, aside from minimal access surgery. We've got two surgeons who we're spending a lot of time together now, and you'll know who they are. And they're working very nicely on their own independently, and we interact when we need to, and happily go into their theatre and so forth. So we are doing that, and we're trying to keep the volume into relatively few hands. As you know, there are many competing forces, such as in-house surgeons, reduced operating sessions, all the other things that are happening within the NHS. But you're quite right, we've got to do that across the board. Someone slipped in somewhere, one of the, it wasn't you I don't think, said, it doesn't matter if you're not a good mitral surgeon. I heard that creep in someone's talk. I think it matters very much that you're a good mitral surgeon for the reasons that Ben and Steve have both so well outlined. You're often operating on more difficult circumstances. You've really got to know what you're doing to give the best result for the patient. But I agree with you. I wouldn't wish to stop you, but I think, you know, somehow you've got to get the volume, you've got to get the numbers. Steve?
I think there's a whole problem with the way we organise surgery in the UK. This is nothing to do with mitral valve surgery. But when we had consultant surgeons appointed when the NHS came, the consultant surgeon was a consultant who consulted. He had his private practice in his clinic, and he came over the bridge to St Thomas's and looked at the patients and consulted. And that's why it's called a consultant in the UK. That's not how we work now. We're all just employees going to work and doing something. And actually, we're all equal. Every consultant in this room is on an equal footing as far as the NHS is concerned. We don't have a chief of service. We don't have anybody in our units planning what the unit's going to look like. We're in Southampton, we're 6 adult surgeons. We're all individuals. We do what we want. We have a referral practice, but we all do what we want. We can't tell each other what to do. And it's probably the same in Brighton. It was probably the same. That's why the UK is actually not going to develop a succession plan and work out which units are going to focus mitral surgery or minimally invasive surgery on the most appropriate people. And we're stuck in this, I'm afraid.
Can I make a comment on that one? So this has been a very interesting day today, I think. I think we've heard a lot, and I think we've learnt a lot about how mitral services are configured in the UK at the moment, and possibly how they should be configured. And actually, some of that's about training, and some of that's also about introduction of things like minimally invasive stuff. But it seems to me that when these various programs were started, minimally invasive programs were started, there was a lot of things we didn't know. And actually, we know a lot more now in terms of what the risks are. So I think if people are taking on a minimally invasive program, they need to demonstrate quite clearly that they are doing all the things that seem to be the concerns which are raised, which Steve raised in his papers. And I think if it is taken on in that way, there still needs to be these caveats made that actually there do seem to be some significant risks associated with this thing, and the patients need to be consented to that. So I think what you learn from this is the idea that you set this up in a way that it's going to take you 4 years to get up to your learning curve, and then you're going to be doing less than one a week is not compatible. David's shaking his head, so he may not agree with that. David, have you got a comment on that?
Well, I agree with you. I'm shaking my head in agreement. My head in agreement, actually,
Meaning that we're spending all this time talking about something that intuitively we know is not sustainable. I'm going to give you an example because we're near Muirfield. I'll tell you what I tell our own patients. And I wish Hugo was here because I was already starting this debate last night with him. We were having a good time. We get an honor of being next to the golf course, which is I tell patients when they ask me, well, how do you decide? Why don't you do this anymore or whatever? I said, let me tell you a story, much to what you were saying, man. I say, so a professional golfer, let's take Phil Mickelson. He goes through a pretty good learning curve. What do you think? He starts out, he gets a tour card, that's impossible. Then he wins majors, that's really hard to do. He wins multiple majors. He's got teachers, psychology coaches, masseuses, people that video his practice swing. He goes to practice before he tees off. He has coaches watching him just before he tees off. For those of you who play golf, that's pretty special. Now he gets out on the golf course, and now your life depends on it, and it's learning curves and this and that. Now let's ask Phil, you guys think about this golfer. He has to hit a driver off the turf on 17 last year. He hit it 270 yards with the bounce, 10 feet below the hole, won the British Open, won the Open. He went through a learning curve. That's a pretty hard shot to hit. Now, what if the same thing happens and instead of having to hit, let's say, a 4-iron to 190 yards, 200 meters away, all he has to do is hit a sand wedge. He's gone through the learning curve for both. There's a gigantic amount of practice associated with both. But we all know hitting that driver off the fairway or a 4-iron to a small green is harder than hitting a sand wedge to a small green. He's thinking 30 feet around the hole from back there in the middle of the fairway. He's thinking 3 feet below the hole when he's got his sand wedge. You know it's harder to do. It's a harder learning curve. It's harder to see. You take more time getting exposure. So by definition, there's a risk. The risk is a tiny bit higher, and it's going to be a little higher if you're a low-volume person, or it's going to be higher if you're low-volume. And I argue, and I've argued many times with Fred and others on podiums, it's going to be higher when you're a master. You start out with a little increased difficulty, you're not going to hit the shot quite as often.
Nice analogy. Could I add one other thought too that really disturbs me about all of this, and that is the marketing side of it. I've had several patients come to me recently who've been consulting minimal access surgeon, and the information they've been given is frankly frightening and wrong. And each of these, they went through a midline stenotomy, went home between 4 and 6 days post-operatively, and could not believe the outcome after the standard approach. They were shocked at what they'd been told before. And I'm very worried about that. I think if it's done in the right way, with proper informed consent, with proper data gathering and giving, that's one thing. But what patients are being told at the moment is very, very worrying, and I'd like to hear from other people if they've heard the same thing.
So,
well, the first one I operated on 3 weeks ago, the most recent one, she was told there was a photograph on the surgeon's wall in the UK, and the one was a massive open chest, as David pointed out, with lots of blood everywhere and a huge incision, and the other one next to it was a girl in a bikini with a scar you couldn't see. Now that is massively distortive, and she went out with not much pain, feeling very happy with a perfect repair, and she'll be fine in 20, 30 years' time. We must stop this. It's got to stop, I think.
every single one of the issues that have been discussed in this session would be addressed by a single high-quality randomized trial. No one has mentioned that. The UK is probably the only place in the world where you could do that trial. We have the funding for that trial. The trial could address all the ethical issues that you're talking about because of the informed consent. It would address all of the funding issues because the NIHR would fund it.
Yeah, the problem with that proposal is that you need equipoise to participate in a randomized trial. And you probably have people on both sides. Hugo will think it's just, a bastardization of mitral valve repair to do a sternotomy. And several of us would have a problem with equipoise randomizing patients to minimally invasive surgery. And what I often tell doctors that ask me, why don't you do it? And you know what I tell them? I'm not willing to go through that learning curve. I can't
actually,
do that.
can I just retort there? Because this is the thing about the UK. we're very different in that our incomes and our livelihood are not dependent on our generating private practice. The strongest proponent of a randomized control trial that I've heard to compare these two techniques came from a minimally invasive mitral valve surgeon today.
Yeah, I'm going to have to stop you. This is fun. This is why it's fun to be in an informal setting at the end of the day. Your implication was we don't have equipoise because we have a private practice. We don't have equipoise because we believe the meta-analysis from the Society of Minimally Invasive Surgery saying there are increased risks with side surgery. That's where the equipoise, I don't have equipoise because I believe until someone proves otherwise, there is a tiny but real difference in stroke rate. And so I don't think it's about how many cases we randomize. It's are we specifically comfortable in going through learning curves? And I think all of us would, very few of us have gone through the learning curves that we've been talking about here.
But actually,
can I just throw in a quick? Just last year, I was standing with two of the very well-known minimal access surgeons, and this subject came up. And I think David's right. It can't be done for that reason. One thing that might be done is entry criteria, which would be the same across 6 centres, with 3 surgeons, say David, Tyrone, Steve, maybe, is selecting the same patients and doing the best they can do. And the same patients being selected by the minimal access surgeons doing the best they can do. And I put it to them. Do you know what they said? No.
I'll absolutely participate.
I will too. I'm up for it. I'm sure.
Well, actually, it should be done by surgeon. You should be randomized to a highly proficient minimally invasive surgeon or to a highly proficient non-minimally invasive surgeon.
No, but I'm saying you can't. I think David's right. You can't set that up because of numbers and all the rest of it.
But you could. In the UK,
but
you could.
set
You could,
up
absolutely.
if centres would be prepared to do this, so they don't change their practice. They continue with their practice, and we have a common group of patients that we operate on. But when you put it to them like that, they don't want to do it.
Gents, having mentioned the bar a little bit earlier, this seems to me an excellent debate to continue outside the meeting. Thank you very much to everybody.
That's a bit of sport.